Hi, how are you? My name is Dr. Charles Beal, and I'm with Dr. Valgimigli from Erasmus University. And we're here to talk about two late-breaking trials. The first is with regards to radial access. And so I just wanted to know the approach and which patients you took in to talk, which patients are included in this paper.
So first of all, thank you so much for having me. So we developed a program which is called Matrix, and actually in that patient population, we recruited an all-comers ACS patient population, which meant ACS across the board, STEMI as well as non-STEMI patients who were supposed to be managed invasively. And so patients got randomly allocated to receive a diagnostic angiogram and if PCI, if clinically indicated, either via radial or femoral approach.
All right. And how were the outcomes? What did it look like with regards to radial versus femoral?
So we pre-specified to have two co-primary endpoints. One was MACE, which stands for Major Adverse Cardiovascular Events, and that's a composite of death, MI, or stroke. And the second co-primary endpoint was NACE, stands for Net Adverse Cardiovascular Events, which is basically a combination of MACE, as defined before, plus major bleeding complication. With respect to the first co-primary endpoint, MACE, we nearly missed the significance p-value because since we had two co-primary endpoints in the study, the alpha level for significance was not nominal 5%, but was actually 2.5%. The p-value for the comparison was 0.03, so slightly above the threshold. So formally, the MACE rate was not lower in the radial patient population. However, with respect to the second co-primary endpoint, the NACE, there was a highly significant reduction with almost 2% absolute difference favoring the radial approach with the number needed to treat for benefit as low as 53. So the data are really in favor of radial approach, and that's something important and I would say even new, because before Matrix, the biggest study performed was Rival, and actually that study was presented at American College of Cardiology maybe 3, 4, 5 years ago. That study included 7,000 ACS patients, and that study failed to show the superiority of radial.
And with regards to bleeding complications, is it about the same or less?
Well, actually, the benefit in favor of radial was driven by two components. From one side, the bleeding complication, which were significantly lower in patients receiving radial access site, and as you may expect, access site bleeding complications were lower, whereas non-access site bleeding complications were pretty much well matched between the two groups. On the other side, I think the most important finding is that we saw a mortality benefit favoring the radial approach of the femoral artery. So it's not just reducing bleeding complications, it's even improving patients' outcome.
But you're also working on another late-breaking trial with regards to anticoagulation use. Can you speak briefly about the trial design and which patients were included in that trial?
So actually, the two studies were nested. That was a sort of a 2x2 factorial design. So patients first get randomly allocated to the access site comparison and only then into the pharmacology comparison as long as a PCI was planned in the non-STEMI patient population. So in the antithrombin comparison, we had 7,213 patients. The patient population is pretty much alike what I described before. It's a combination of STEMI versus non-STEMI. It's a mixed bag of all-comers ACS. And for that comparison, also we had two co-primary endpoints, MACE and NACE as described before. Unlike for the access site comparison, both co-primary endpoints were negative here, but if you broke down these composite endpoint into the individual components, we did see also in favor of Bivalirudin a bleeding as well as a mortality advantage. And numerically speaking, both bleeding and mortality advantage were even sounder than what we saw in the access site comparison.